Hi, I'm Dr. Gil Wilshire. I'm a board-certified physician, surgeon, and reproductive endocrinologist. Welcome to my series of podcasts where we discuss medical matters that matter to you. I'll be interviewing top experts in their fields, and we'll also be delving into fascinating backstories from deep within the world of medicine. So, I'm confident you'll find the information in these podcasts valuable, and they will assist you on your journey to optimum health. Welcome to the Dr. Gil Show. This is where we talk about medical matters that matter to you. And remember, you can trust me because I'm a doctor. Gets them every time. My guest today is Dr. Clay Mechlin. Welcome to the show, Clay.
Thank you. Thank you.
Clay is both a friend and a colleague of mine. We work very closely together. Clay is a urologist and a urologist with subspecialty training in the treatment of male infertility. Now, Clay, was there a point in your life, in your childhood, when you decided or you thought, gee, I want to be a doctor?
I kind of always liked anatomy. I was really interested in anatomy and the sciences associated with that, biology, all of that. And so and that was even as, high school, maybe even junior high, I kind of gravitated toward that. And yeah.
Now, is your dad a doctor?
Yeah.
Your father?
He's an ear, nose, and throat.
Now, were you one of those kids that he can be any kind of doctor he wants to be, or did they really push you into medicine, or did you have latitude?
He really didn't. I mean, I think, of course, he always thought that would be nice, or would have liked maybe me to do that, would have gladly had me join his practice. But he was very supportive. He didn't really care. He was fine.
Didn't force you into medical school.
Didn't force me to be a booger picker.
Okay. Is that what ENT guys are? I love it. Booger pickers. I'm going to use that on my next ENT doctor. I have one lined up right now. We'll talk about cochlear implants and booger picking. So, Clay, you went to university here at Mizzou in Columbia, Missouri?
Mm-hmm. Yep. Yes.
So in preparing for this interview, Clay, I revisited the history of urology, one of the first surgical practices on human beings. And I don't know if our audience knows, when you lie on your back with your legs up, it's called lithotomy position. The patient was placed in lithotomy position. When you think about it, lith means stone, and otomy means making a hole in something. So it is essentially the position for cutting for stones. And painful bladder stones, urinary tract stones, have plagued humanity forever. And these early pioneers in surgery would cut for stone in the most horrific ways you can imagine. They've got pictures of the tools that they developed, this early surgical instruments that they did to cut for stones. And people were in so much pain they would lie there and be So tell me about, urology is one of the oldest surgical specialties. Tell me a little bit about the history of urology.
Yeah. Well, I think that the thing that's most interesting is how all the endoscopic, minimally invasive equipment has come about. I mean, in the beginning you had what you're talking about, where basically somebody's putting a metal rod in there and feeling if it hits a stone and then hitting it with a hammer and trying to break
it.
Can you imagine if you were awake and you could hear the guy tapping and getting ready to find it?
Break it with almost a chisel.
Yeah, probably a high mortality rate on that procedure.
Oh my God.
But so we started with that medieval stuff, but then it's come a long way. So they had early scopes that actually used candles for light. I mean, all kinds of crazy stuff to look in. Through the penis, through the natural openings. And then those have kind of morphed to fiber optics and what we have today. And there's quite a bit of different phases or transitions along the line. But that's where it started. And I mean, it's not just patients too. I mean, can you imagine urologists, what you would have to do? I mean, these guys had serious neck and back problems because
Ah.
there's no looking at a screen. They had to bend over and look through the scope, you know,
or the
where it enters the
speculum or
penis
the
or where, yeah.
retractors.
So I mean, for hours they're bent over doing this stuff.
I know cutting for stones, it was like the real good guys could do it in under a minute.
Yeah.
You know, that was quick. They'd go in, they'd push it down. Oh my God, just horrendous.
Yeah.
So urology has a long history. Now, what some people don't realize is that urologists, you treat the urinary system. So men and women have need of urologists. So the urinary system starts up in the kidneys. Most people have 2 kidneys, right?
Yeah.
And it goes through a tube usually one tube from the kidney down to the bladder. And men and women are essentially the same there. And we can all suffer from infections and from stones. So let's talk about infections. You hear about women getting chronic urinary tract infections or kidney infections and whatnot. How big of a problem is that?
Well, I think there are kind of 2 things we see. We see infections in people with anatomical problems. So it's just like any other system. So you think of a freshwater stream, so nice, clean, you can drink from it, versus a stagnant pond water.
Right.
So you want the freshwater stream. You want your system to flow freely, no blockage.
Mm-hmm.
You know, that helps prevent bacteria. So if you get a stone and you have some bacteria, it becomes a much worse infection because you get a buildup behind the blockage. It goes into the bloodstream. You can get very, very sick. Whereas if you didn't have a stone, then it would probably burn when you went to the bathroom, be uncomfortable, but you're not going to be in the hospital with a potentially life-threatening condition. So, there's anatomic reasons why we get more serious infections.
So if a woman is getting recurrent urinary tract infections, it could be due to something abnormal in her anatomy. Something's just not quite right, working quite right, or a stone or something.
Not emptying their bladder.
Not emptying their bladder.
This type of thing.
So if a woman or a man is getting recurrent infections, they really ought to see a urologist to find out what the problem is.
Yeah.
Now let's talk about stones. Stones have clearly been with us forever. I was also surprised to see a lot of stories about children getting stones. What causes kidney and urinary tract stones?
Yeah, so you have genetic reasons and you have dietary reasons, and so more often in a child, that's gonna be a genetic reason. They just have a predisposition to form certain types of stones because of the ways they concentrate calcium in the urine, or uric acid, or these common types of salts that we find in the stone. So there's usually an anatomic reason why a kid would get a stone.
Or a metabolism, their way their enzymes work, they make more of this or that or whatnot. So a metabolic source of stones. And that can affect children and men and women.
Yeah.
Boy, so do stones always start up in the kidney, or can they form in the bladder too? Well, where do stones come from?
Right. So usually they start in the kidney. They start forming little calcifications on the lining of the collecting system where the urine concentrates before it goes down and goes out the bladder. Those are called Randall's plaques. But then the stone starts to form and then it falls off, and you don't really know it's there while it's forming. It's only when it falls off and can plug the drain that you feel pain. Because otherwise, it's like a marble in the bathtub doesn't cause a problem unless it goes down the drain and stops it up.
I love it.
So
great analogy. So some people are just predisposed to stones. I know there's a lot of controversy on what diets might or might not. Now, is it true that spinach that has a lot of oxalate or oxalic acid, does that encourage stone formation?
Yeah. The most common type of stone is calcium oxalate. So oxalate can form stones. Now, it's pretty uncommon that just eating spinach is going to cause a stone by itself. Usually there's some propensity to form those types of stones. Some of the diets that we see that can contribute are diabetic diets, like the high protein, the keto diets that make you a little acidotic, and that can promote stone
You think
formation.
they can, huh? Interesting. Interesting. But if you're not predisposed to stones, it shouldn't be an issue.
Shouldn't be an issue, yeah.
Interesting. Now, let's say somebody has stones. What are the various things you have to do short of the medieval cutting for stones, barbaric procedures? You have much more precise, elegant ways to treat stones nowadays, don't you?
So it depends on the size and if there are any complicating factors. So if you don't have severe infection, you don't have any sign of kidney damage, you're able to tolerate, get some food down, drink, and your pain can be controlled, then if the stones are small enough, we can give you what we call a trial of passage or let you try and pass the stones. That's usually stones that are 5 millimeters or less, but everybody's a little different.
5 millimeters. Okay.
Mm-hmm. Yeah.
Okay. So now, do you need an IV to hydrate you, or can you just drink a lot of fluids?
No, you can, as long as you can keep them down, and sometimes people get pretty severe nausea with a stone. So as long as you're able to keep fluids down and get pain control with those types of stones, you can try and pass them.
How do you know how big they are?
So X-rays or CAT scans.
CAT scans. I thought a lot of stones you couldn't see, or can you image most stones?
Yeah, the vast majority of stones which have calcium in them will show up on X-ray or CAT scan.
Good.
They will almost all of them will show up on CAT scan. There are a couple of very rare things, but you almost never see those.
Okay.
But uric acid stones will not show up on a plain X-ray. Now that's the minority of stones, but some people, people that have gout, have high uric acid levels, they're going to have uric acid stones most likely.
Gotcha. So let's say you've got a bigger stone in your kidney.
Mm-hmm.
What can you do to treat that?
So, we talked about less than 5 millimeters. You'll go, about 5 millimeters to 1.5 centimeters. We treat that either with shockwave.
What's that? Is that called lithotripsy?
Right.
What does that involve?
So that involves, we do put people to sleep. You're flat on a table, and we send sound waves or shock waves from outside the body directed at the stone with the aid of X-ray to break up the stone.
So you're not in a tub. I thought you were in a tub for that.
No, that's
how
old
much
school.
I know.
Yeah,
old school. So it used to be in a tub.
Yeah,
but now they put you to sleep because it hurts.
Yeah,
and they send powerful shock waves and they focus them, and you use an X-ray, and you can actually break up these big stones.
Them up, so we don't have to go inside. So a little less invasive.
Sometimes, and then do they pass?
Yeah, and then the goal is to pass all the pieces or the sand out afterwards. Sometimes we put a little stent in to help them pass.
A stent, that's a little tube. So you'd put a telescope in the bladder called a cystoscope, and you'd pass a little tube up the urethra to the kidney.
Right.
And they have little curly cues on the end.
That's right, to keep them in place.
So they're called pigtails, right?
Yep.
Am I right?
Yep.
So you turn this stone into sand or sludge or whatever, put a stent up there,
right?
Hydrate well, and they just literally wash out?
That's the goal, yeah.
Wow.
Yeah.
Now, what if it doesn't break up or whatnot? How do you get what can you do about those with those stones rather than making a huge incision in your belly or your flank?
Right. So if they don't break up, every once in a while there'll be a little bigger piece left over. We go in with a little telescope through the natural openings, where you urinate from.
So you go through the urethra, guy or gal,
yep,
into the bladder, and then you continue up the ureter.
All the way up.
Well, you've got scopes small enough to do that.
Yep, that's
you can actually see.
We can see. We can also pass baskets and lasers through there to break up the stone and remove them.
So you can get the stone out, break them up more, or put it back and actually withdraw them and take them out precisely.
Yeah.
Fascinating. So in that way, you can really help. You can cure the stones then, and not damage the patient with an unnecessary surgery.
Yeah. Yeah, it's pretty rare to make a big open incision now. Even the really big stones, 3 centimeters, golf ball, huge stones, we can go through the back with basically a little tube.
Okay.
So puncture mark a little tube and use ultrasonic equipment to break up the stone, suction out the stone. So basically, there's just a puncture mark that we don't even put sutures in. It just seals up on itself.
Wow, that's elegant. And while we're talking about kidneys, let's stay on kidneys. Do you treat kidney cancers?
I do treat some.
So, how would one know if they have a kidney cancer? Do you pass blood in your urine, or have pain, or how does one even know?
Yeah, most commonly nowadays, It's either found from a workup for blood in the urine, which could be something that you can see with your own eyes, or microscopic, where they do just a screening urine test with your primary doc.
It shows up on a dipstick.
Right.
Your urine doesn't look bloody, but it shows up on the stick. Okay.
But they see it. And so we do a workup where we check to see if there are any tumors or kidney stones, and that involves a CAT scan, and we find it that way. Or people have what's called an incidental renal mass, where they went into the ER because they thought they had appendicitis, and then they get a CAT scan, and then they find these things that are teensy tiny, 1 centimeter.
Gotcha. We call them incidentalomas, found incidentally. That's the reason they don't offer CAT scans in the shopping mall anymore. They used to have, I don't know, 20 years ago, they take a semi truck. It was a business. You bring a semi truck with a CAT scan in it, and you'd have a barker go to the hallway. Come get your CAT scan here. Check everything, right? Everybody say, "Oh, I got to check everything."
Yeah.
And then they find these things they wish they didn't find.
And they're so small now that sometimes we just watch them, or and see, because it's hard to tell when they're so small what it is.
So can you biopsy them? Can you go in there and do these little directed biopsies?
Yep. CT guided biopsies.
And you do those?
The interventional radiologist does.
They'll even do that for you.
Yeah.
Now, if they find something, you are prepared to take out a kidney and the surrounding tissues.
Right.
Now, I assume kidney transplants are done at special transplant centers, right? That you need a whole team for that, right? So you could do it, but you'd have to be in the context of a team, so you can take care of. And sometimes people are born with abnormal kidneys, right? That aren't working well, or malshaped.
There are conditions where they don't drain properly, or you get reflux, or the urine gets backed up, making you prone to infections. I don't do peds outside of maybe kidney stones. Or
peds mean pediatric, meaning children.
Yeah, pediatric urology.
So there is a specialty called pediatric urology, where someone's done additional probably years of training just for kids.
Yeah.
Okay. Good. So, but if a kidney's malfunctioning and the other one is good, you certainly are more than qualified to just take the kidney out.
Yeah. Right.
Yeah. Gotcha. So working our way down now, we've talked about stones, talked about infections. Now, in women, especially after they've had a baby or two, and I still can, I delivered about 1,000 babies in my training. I'm not an obstetric. I don't do obstetrics, but I still can't believe a baby can come out the pelvis and not kill the woman. I mean, it just seems like such a traumatic thing. But in the process, it's stretching the fibers that hold up the bladder, for example. And women, after they've had a few kids, can become incontinent. They sneeze. It's called spending a penny. You sneeze, you lose some urine, and sometimes it can be very, very serious. So female incontinence is a real thing. Now, is that something you would treat? Like in the world of OBGYN, there is a whole bona fide subspecialty of pelvic reconstructive surgery where the GYNs are doing a lot of this incontinence.
Urogynecology.
Urogynecology. Now, have they taken that away from you, or are you glad to not to do it?
It's not. I mean, we'll talk about what I kind of focus on in my subspecialty later.
Sure.
But there are urologists that do fellowships in that.
Right.
Urogynecologists that do fellowships and are trained for that.
Uh-huh.
Now, some of the more straightforward things, that we will treat. We would treat. When I say we, like in my practice, we would treat urge incontinence as opposed to stress incontinence. So urge incontinence, it's got to go. Oh, I couldn't hold it. I had an accident. That could be treated medically with medications or Botox injections, things like that.
So that's something you could do, and any good general urologist could treat.
Yeah. But, just like we'll talk about implants later, you want somebody that's done a lot of them. You don't want some guy that does one hip a year to do your hip replacement.
Right.
So we tend to, in urology, subspecialize in some of those more complicated prosthetic or reconstructive areas.
All right. So I'm going to leave the combined male and female world of urology, and now we're going to get to the male world.
Yeah.
Like Mr. Rogers said,
it's interesting stuff.
The interesting stuff. I think Mr. Rogers said, girls are fancy on the inside and boys are fancy on the outside.
Okay.
So we're going to start talking about the boys a little bit here. Now, I believe one of the most common urologic surgeries is a vasectomy, just by numbers.
I could imagine.
Lots of now, do you do vasectomies?
Oh yeah.
Yeah. No, I've heard of one guy, having a couple drinks, a urologist, and and actually doing his own vasectomy.
Oh yeah.
I've heard that is a thing. It has been done.
I have not done that.
Yeah, I would be terrified. I mean,
I'd hate for my wife to find me like passed out on the floor halfway through a vasectomy.
I have enough trouble with a mole or a hair or something on my body, let alone that. So, vasectomy, is it a fairly simple procedure?
Yeah.
Is it an outpatient procedure?
Oh yeah, I do it under awake, just like I'm talking to you. I would be talking to the guy with a local anesthetic, and it takes about 15 minutes to do.
15 minutes.
Yeah.
I know there's many ways to tie a fallopian tube. I'm sure there's a number of ways to tie a vas. But if a guy is potentially not sure, he has some doubt. I mean, you don't want to do a vasectomy on anybody who has doubts, but sometimes you can foresee if the guy's 23 years old, he has 5 kids, but his life may be changing in 10 years.
Yeah.
Are there any vasectomies that are less destructive, that are most easily reversed?
Well, the easiest way to reverse it would be if you had just put a clip on it and didn't take out a big section. However, that's going to be the least effective at.
So if you take out just a little piece, put on a couple clips, there's more likely that a fistula or a connection will form and sperm still might be sneaking out. Is that what you're saying?
Yeah. The two things that have shown to decrease failure clinically through trials, it's going to be what we call fascial interposition. So that means that you put tissue between the two ends. Whether you let one end retract and bury it with a clip, whatever, you have tissue between the two ends so they can't just grow back together.
Gotcha.
And then the next one is going to be where you take out a section and cauterize the inside of the downstream part of the tube.
Gotcha.
So that there's no more lumen or opening. It's just blind ending.
It's burning, it scars right down.
Yeah.
Gotcha.
Yeah.
Gotcha. And you can once again do that under local very easily. And if you go to an experienced surgeon like you, what would the failure rate in that be? 1%, 1 in 1,000?
I quote the AUA, that's our national guidelines for urology. I quote 1 in 2,000, which is what's in their guidelines. I mean, I think it's pretty rare.
0.05% if I'm doing the math right. Yeah.
Rare.
Right.
Yeah.
Fantastic. So very easily done. Now, sticking in the scrotal area here, there's a common condition where a guy has a big, massive veins in the scrotum called a varicocele. Yeah. I understand that you do a lot of surgeries to repair or get those veins out of the scrotum to help male fertility. So I thought those veins increase the temperature, particularly on the testicle on that side. And taking out those veins can improve the function of that testicle. Is that true?
That's true. So just like you see people with big veins in the back of their legs, and those people can have pain in their legs from those veins, same concept. You have poor blood flow or stagnant blood flow, buildup of inflammatory substances or reactive oxygen species, just basically toxins, And so that can damage the sperm or the cells even the cells that make testosterone can be affected. And there's been a lot of people trying to figure out exactly how this works. We don't know exactly. We know it has something to do with thermal regulation and, just healthy blood flow to the testicles. But we don't know the exact mechanism, but it's very clear that fixing them is beneficial in the right individuals.
And if you wait, you have to wait like 6 months, 9 months to see improvement, or sperm parameters? Yeah.
So what I do is you do the surgery, and then at 3 months we do our first semen analysis.
Okay.
And usually you can see some improvement.
That quickly, even after 3 months?
Yep. Usually at 6 to 7 months you'll see kind of the maximum improvement.
A max out there.
Yeah.
So the results can be fairly quick. Okay, that's good to know. Now, there's other messes. Let's say, they tell women to do a breast exam in the shower because that's when everything's slippy, soapy, and smooth. They recommend that guys do testicular exams in the shower as well. Everything's warm. It's easier to feel things. So if a guy, and a gentleman, a man should examine himself, once a month, once a year?
Once
Are
a
there
month.
there's
Yeah,
guidelines for that?
Yeah.
So let's say you're taking your shower, you're saying, hey, it's the first of the month, I'll do my self-exam. If you feel a mass in there, it's not always a cancer, is it?
No. I mean, there are a couple possibilities there based on your history. I mean, have you had scar tissue, trauma to that area, infections? There can be benign masses. You can get little calcifications, called them scrotal pearls in there.
Little pearls in there. Okay,
So little
so you're doing the
calcifications
exam,
in there.
there's something new in there.
Yeah.
You shouldn't get terrified and figure you have a cancer. You should go see your
Well,
urologist.
you should get it checked out. Absolutely.
So someone who's experienced doing this. And can I say that most of these masses are benign, meaning not cancer?
You know, if you're talking about the scrotum, I would say yeah. If you're talking about just the testicle,
Okay.
you know, if it's just the testicle and you're in that 20 to 30-year-old range in a man,
Okay.
you got to take it serious. I mean, you got to get
So
it checked out.
this is I'm glad we're talking about this. So you're doing your exam. Now I believe a testicle has a little epididymis on it. So it's round and there's just a little kind of tail off the side of it. That's normal. So that's not a mass.
Right.
Right. And that's where if you're doing this every month, you kind of know, well,
You gotta
that's where
feel
the
that.
that's where the tail is. That's normal for me. Like women with breast exams, they know where the glands are. They say,
Right.
this is my
Right.
normal.
Yeah.
This is my normal. But is there something new? Then testicular cancer is a thing.
Yeah.
isn't
I
it?
mean, if it's hard, it feels like a rock in there. It's hard. It's new. And testicular cancer grows extremely fast.
Fast.
So, I mean, within a week, it's going to
Oh my
double,
goodness, a
you
week.
know, very fast. So you'll know. I mean, it's not like, and it's crazy how long people wait to come in. I mean,
Oh,
softball size,
Yeah.
rock hard. I mean, it's just like, oh man.
Yeah, so didn't you know? Yeah, we see that all over the body, especially in
Yeah.
my world too. You say, didn't you notice this? Or,
Yeah.
oh, I thought it was a yeast infection. Yeah, it's
Yeah.
yeah.
I think they're just embarrassed about
Yeah,
that
sure.
area.
It's
And
a sensitive area.
yeah, but unfortunately, you just gotta.
So if there's a mass
Check
there
it
that's
out.
new, you get to see
Yeah.
your urologist. I see these ads on TV about a bent carrot.
Mm-hmm.
Something about a bent carrot. They don't say anything else except something. I think one of it is Peyronie's disease. Is
Yeah.
that what we're talking about?
Yeah.
Please enlighten me. What is
Yeah.
this bent carrot Peyronie's disease all about?
Yeah. So that's something I see a lot of, and you know, that can, as opposed to some of the erectile dysfunction, tends to affect older gentlemen. This can affect very young people. I mean, 20s, 30s. As well as older individuals.
So how does the guy know? Is this when he has an erection? There's a bend or something?
So there's kind of two ways it comes about. One is there's clearly a traumatic event. Usually, wife's on top, slides out, comes down hard on
so
it.
you can actually. This is not a myth. You can break your penis.
Oh yeah, absolutely.
You can break your penis.
You can break.
All right.
I mean, they hear a snap
Oh.
and it immediately deflates and it's purple
that's
and
a-
it's swelled up like an eggplant. I mean,
Oh, that's not good.
oh yeah.
Does it hurt?
Yeah, but I mean they're in pain initially, but within 24 hours it tends to go down. And sometimes people, that's why they delay coming in. But you want to get in right away if that happens.
Get right away. So if you can break your
It's
penis,
not
and if
subtle.
it happens, it's not subtle.
Like,
All right, so that's one way. Okay, this is
Yeah.
right up there with lithotomy, cutting for stones.
that's one.
in.
So the other one is usually it's guys their erections aren't as hard as they used to be. They're having intercourse, and there's kind of some almost like micro trauma. They don't realize it, but they're trying to kind of force it in, or it's not quite hard enough, and there's just things are bending.
and that can also traumatize.
And you don't see the bruising or the swelling, but you get scarring in there. And so the penis is kind of unique because it's basically just a completely elastic organ.
Okay.
And so there's almost like a sausage casing. There's two elastic tubes that fill up with blood.
There's the two. Are those the cavernosa?
On the top, yeah.
Corpora cavernosa.
Cavernosa, yeah.
Okay.
So the spongy erectile tissue that fills up with blood, and as it fills up, the pressure goes up, and those stretch out to make it larger, and they get hard.
Because it meets resistance, right? Because there's
I mean, you got to think how much it stretches. So nowhere else in the body does it. I mean, nothing stretches
nothing's like
that.
that.
The problem is that
there's a joke about the iris. It grows.
Yeah.
The only part that grows as much.
Yeah. So when it gets injured, it forms a scar. There's no more elastic tissue there, and so it's a hard scar. And then that doesn't stretch. So because it doesn't stretch, it's going to curve to that side. Okay.
All right. So now we've got a damaged penis that has a funny bend to it, the bent carrot. They say, what can you do about it, doctor?
Yeah. I mean, it depends how bad it is. So we usually say it's less than 30 degrees. That's really almost cosmetic. That's
30 degrees. That's
if it's less than 30, usually it doesn't interfere with function.
Okay. So if it ain't too broke, don't fix it.
Right. Don't try to fix it if it's not going to hurt anything.
Then why are there ads on TV?
Well, because we see a lot of them that are worse than that.
And what is this thing on TV that it's not a drug?
No, you're probably seeing Xiaflex commercial. So if the scar, and you can feel it, there's a scar in there. If that is 30 to, technically it's 90 degrees, but that's pretty.
90 degrees.
Usually 30 to 60. No, I mean.
I'm just trying to picture that.
I see it all the time. I mean, it's bad.
That's bad.
Yeah, I mean,
can't have intercourse at 90 degrees.
No. I mean, it's like a right angle.
So why are these ads on TV if it's not for a drug? Well, what can do? Is there some device they're selling or some implant?
Xiaflex is a material that you inject into the scar to help dissolve the scar.
Okay. Well, that makes sense. So it's a biotech or a biomedical injection substance.
Yeah.
Okay, I could see paying for TV commercials for that.
Yeah, so it was
probably not cheap.
they have millions of dollars. The company that makes the
gotcha. So it's they're marketing an injection
that
you would put in just right. And what does that do? How does it dissolve the scar?
Tries to dissolve the scar.
So it's on the tight side.
Yeah.
The contracted side, it'll dissolve it and it'll straighten out more.
Yeah.
That's what's happening.
Yeah. And so we do that. I mean, that works better for things that aren't as severe as 90 degrees. It's a series of injections in the office, so it's not very invasive,
Is it expensive? And does insurance pay for it?
They do usually pay for it.
It's super expensive because they're paying for those ads.
Yeah.
Those fancy
but
ads.
It is very expensive. And it was actually derived from people that have Dupuytren's contractures.
The hand. The hand will contract too.
They started injecting into the hand, and they figured out maybe, I don't know how they thought about, why don't we inject into
Makes sense.
the penis?
Dupuytren contracture is a scar.
Yeah. So that was the first indication, and then the Peyronie's was the next one for this drug.
So Peyronie's is the break you're talking about in the scar tissue. It's another name for the same thing.
The scar tissue, Peyronie's disease.
The Peyronie's disease.
Yeah.
Okay.
Yeah.
Okay.
Yeah.
Very interesting. Okay. Now, there's the general topic of erectile dysfunction. And as I understand it, one of the most common causes is diabetes or vascular disease, which is blood vessel disease.
Yeah.
Blood doesn't flow like it used to. And you can take a pill, something like Viagra or related, which dilates the blood. But apparently, Viagra you probably know this, was discovered by accident. It's a phosphodiesterase type 2 or whatever inhibitor. And they were using it, ostensibly they were studying it for the heart to dilate blood vessels in the heart, right, to see if you get better blood flow.
Pulmonary hypertension.
Yeah, pulmonary, And they were testing it for chest or heart and lung disease, right? And they would interview the guys, right, your side effects and blah, blah, blah. And it wasn't on the list, but guys kept saying, oh, and by the way, I got a raging hard-on when I took this medicine.
Yeah.
And eventually they said, wait a minute, this is... and they figured out this phosphodiesterase inhibitor was good for these blood vessels.
Yeah.
I think I'm right.
Yeah.
Story. Yeah. So if you have got mild vascular disease, you can take a pill. If you've got some stage fright or you're taking some other medicines that interfere or low testosterone or something, then these pills work for erectile dysfunction. But what happens if the disease is so bad or the blood vessels have been so destroyed? Or I understand if a guy's had an erection for too long, is it called priapism?
Yeah.
And the blood is clotted and it's destroyed these cavernosa, and you can't get an erection with pills.
Yeah.
With pills, well, you can do a lot of things for these men, can't you?
Yeah, yeah. And even some people with that condition, the Peyronie's disease, that's severe, they also fall into this bucket. But, injections are less invasive, which we always offer people. You give yourself an injection.
What do you mean injections?
So you inject a material straight into the penis.
A drug.
A drug.
A dilating drug.
That dilates the blood vessels to give them an erection. That works if the nerves don't work. Maybe you had your prostate out for prostate cancer and the nerves were damaged.
Okay.
Viagra won't work if the nerves are damaged. The nerves have to be intact for those drugs to work.
I didn't know that.
Yeah. Yep, because it prolongs the effect of the nitric oxide. So the nerve endings release the nitric oxide. And there's a material that
dilates blood vessels.
Right. And then there's an enzyme that breaks that down. Well, we prevent it from breaking down the nitric oxide with the Viagra so that it lasts longer. The effect lasts longer. But if the nerves are damaged, it doesn't matter.
So you can inject an active medication, and I assume it's on the shaft, so it's not
penis,
very sensitive.
In the corpora,
so in the
those
corpora,
tubes we were talking about.
So you can take a little injection.
Yep.
And it doesn't hurt that bad.
It's like an insulin syringe,
it's a tiny
very tiny
needle. So you can inject the medicine directly there, and it's successful.
In a lot of people. I mean, it's not a guarantee. I mean, there are risks of that. Besides just not working, you can overdo it. So you actually give yourself that priapism, and then you went from being able to have sex to sitting in the emergency room to wait on a very embarrassing consult.
And don't they have to somehow wash the clots out?
Sometimes we can just inject a reversal, an antidote,
really
to constrict the blood vessels to get it to go down.
I am learning so much here. There's an antidote.
Yes.
You can inject a penile antidote.
That's right.
Bring the anti-serum.
Yes, that's right. Yeah, you're basically
bring it out on
constricting. On
the
how much?
So you don't. I heard that you'd have to wash the clots out.
If it's past the point of the medication working, then you do.
And you need a urologist.
And that can go from just with a needle to having to go to surgery to. We used to see it really bad in sickle cell patients.
Yes.
You still do, but I don't see that population here very often. But in New York, obviously a lot of we would see those people coming into it'd be the same guys coming into the ER
over and over. Poor guys. Yeah. So let's say the injectable medicines don't even work anymore. What can you do for gentlemen with this problem?
So then
permanent erectile dysfunction.
So a permanent solution would be an inflatable penile prosthesis.
Inflatable penile prosthesis.
That's right.
Tell me more.
Okay. So basically, instead of relying on those two tubes that fill up with blood that we've been talking about injecting and all that stuff, we put a inflatable cylinder inside that space. We don't remove anything.
You can just insert
put it in
right
there
up.
And it fills up with saline or salt water, the same solution as all the cells in your body.
Okay.
It's done through a small incision about 1 inch long above the base of the penis. Okay. And there's a little pump in the sac between the testicles.
In the scrotum. A little pump. So if you want to get it up, you just squeeze, you just pump it up. And pumps up the jams.
Yep. Just like it's underneath the skin, so nobody could tell that it's in there after you're all healed up. And there's a reservoir behind the pubic bone or underneath the abdominal wall so that all the fluid can go out. So that it's very natural while you're walking around. You can ride a bike, exercise.
Horseback ride.
Yeah.
You can do it yourself. And now is there a chance that might get infected?
Yeah, any foreign body, just like if we place your knee, your hip, whatever. There's always a chance of infection. It's very low. All the devices are coated with antibiotics. I do some techniques to help decrease that even further. We usually quote people 1 to 2%. I think it's probably not even that high in somebody without diabetes, but with diabetes, that's what we usually quote them. I always make sure their diabetes is under really good control before I would do the surgery. But we do a lot of diabetics because those are the people that have a lot of vascular disease.
And with an experienced surgeon like you who does a lot of them, complication rates are low.
Yeah. Yep.
Now, is that the state of the art, the pump up kind? So I know they used to make these kind that would just bend. It was like a permanent
there's
erection.
something called malleable rods. If you ever seen the gooseneck lamp where you can just kind of bend it,
Just bend it, and
it'll
there it is.
stay. You know, there are a few guys that I'll do that in with, just maybe they don't have great manual dexterity, or they just want something, they're older, 80, they want something very simple.
Right.
We'll do it. I don't do a lot because they're just, no reason. You could have more complications from erosion, things like that, because it's a rod pushing on the tissue the whole time.
So the pump up prosthesis is state of the art, and that's what you would want.
Yeah.
Right. I joke about getting a nuclear powered one. So you have to pump it
you should. They when you go to meetings, they have all kinds of stuff they're working on, remote controls and
an app, right?
They had one that
I would like an erection at 10 p.m.
They had this prototype where it would change depending on the temperature. So, like if it was cold, I can't remember if it was hotter, it would get hard, or colder. You had this wand you were supposed to wave over it. And, there's all kinds of research going on about that.
Amazing.
Yeah. You got to argue. If you don't have the ability to pump it up,
you're probably not going to be
don't need
too.
it.
You're probably
I
not,
guess there are certain situations, but
gotcha. Now, if a man has incontinence, we're going to get to prostate surgery in a little bit. But let's say he's got diabetes. I think the normal sphincters aren't working, or he's had surgery or something that's lost the nerves or whatnot. Or maybe, does a spinal cord injury cause incontinence?
Yeah, it can, depending on where it is.
And so, do you have, or a sphincter is a circular muscle that will contract. Your iris is a sphincter. Your anus is a sphincter. We have sphincters everywhere. Do you have artificial sphincters that you can implant in men who are leaking urine to give them continence? Tell me about that.
Yeah, that is something I do. So, where I most commonly do that is in patients that have had their prostate removed and they had complications. Maybe their cancer came back, they needed radiation, or they were older when they had it done, and so they're leaking substantially because that sphincter, that prostate lies right on top of that sphincter. So, you're basically sewing right on that sphincter when you reattach everything or reconstruct the bladder.
All right, so you're in the man. The urethra's here, the bladder's here, the prostate's in between. So if you take out the prostate, you got to put them back together.
Got to sew them back
together. So that sphincter can be damaged by those stitches and the surgery in general.
You're also shortening the urethra. That's why women tend to have so much more stress incontinence, because there's less resistance, because that tube is so short.
It's shorter.
Just physics, the longer the tube, the more resistance, that goes through there. So by taking that out, you're shortening that tube. So basically what we do is we go in and we put a new gasket on there. And just like for that penile prosthesis, you squeeze a pump in the scrotum. There's a pump for this one too. So when you feel full, you want to go to the bathroom, you go stand there, you squeeze the pump, pushes the fluid out.
And it lowers the pressure. So
and
the
it opens
relaxes.
Yep.
So you can solve male incontinence that way.
Yeah.
That must be dreadful, dribbling on yourself the whole time.
Oh, those are like the happiest patients. It's the most rewarding thing you can do, because they're just, it's just, can you imagine just sitting in a soaking wet
all the time?
Skin is all irritated.
It
It's
smells
terrible.
bad. Just miserable.
They just don't even go out in public. Some of these, it's just, some guys will even put basically like a safety clip or a safety pin clamp on the tip of their penis
just to keep it
clamp
closed.
it off. Yeah.
Oh, because they're
trying to keep it from leaking.
Suffering so.
Yeah.
Well, that's good to know. You can do that for people. That's wonderful. Now, the next bugaboo of the male anatomy, the prostate gland. I'm going to say it again. The prostate's between the urethra and the penis and the bladder. It's just part of sexual function. It contributes to seminal fluid. I think it adds like 10 or 20% of the seminal fluid. And bladder, your urine must go through it. And unfortunately, it seems that in men, the prostate grows over time.
That's right.
And it can constrict the urinary flow. So it causes a lot of problems. And I see all these ads on TV for prostate treatments, prostate medicines, prostate herbs, all this stuff in the middle. And they're on in the middle of the night because they know we're getting up to pee in the middle of the night. So tell us a little bit. Let's talk prostate for a little bit, Clyde. Is it
Yeah.
true that if a man lives long enough, he has like at least a 70% chance of getting prostate cancer? Is that a
Yeah.
number?
That's
is that a
that's
number?
true. Yeah, I mean, once you get into your 80s, 90s, you know, usually it's the slow. By that point, if you're asymptomatic, a lot of times it's the slow growing.
Okay.
So it might not ever affect you in your lifetime, but it could. If you're a good, healthy 80-year-old, it could still affect you.
Okay.
But if you were just to do autopsies on everybody and they died of other causes and they're 80 to 90 years old, you would find something like that in terms of the.
That's 70%
Yeah.
a number.
Yeah.
If you look hard, I know that 15% of the time you'll find something in the pituitary, unrecognized. All comers.
Yeah.
All comers. Now, as far as screening for prostate cancer, I think the go-to thing that everybody talks about is the PSA, a blood test looking for prostate-specific antigen. Is that generally what most doctors do to screen for prostate cancer, or is there a role of a digital rectal exam by a primary care or urologist?
Yeah, so there are two things that we recommend for screening for prostate cancer, and that's what our national guidelines say, at least in urology, and that is the PSA test and the digital rectal exam. And neither one is perfect, but it's a very inexpensive, simple test, and it's a good start. So our goal with any type of screening is to find something before it's a problem, before it's spread or there's more morbidity associated with treating it. So the PSA is a natural protein that's found in all prostate cells, but the cancer cells tend to make more PSA.
Okay. That's why you don't have zero. You don't walk around with zero.
No, it is zero, right.
You walk around with 1 or something.
Right. And if you have a bad infection in your prostate, the number could be very high because those cells are damaged and they're leaking that PSA out.
So it's not always cancer. You get what's called a false positive.
Right.
Now, do you think family doctors or internists or somebody do enough prostate exams for the digital exam to be even meaningful?
Well, unfortunately, a lot of them don't do it at all. I mean,
I've noticed that.
Patients come and nobody does it. Nobody has it.
Right.
And, I'm sure there are other reasons besides urology to do a rectal exam. I mean, rectal cancer, all these types of
rectal
things.
cancer. My goodness.
It's surprising that, people don't get a yearly check. But what we're looking for is advanced bad cancer. Very hard, large nodule or rock, something that's saying, whoa.
So any competent, experienced primary care doctor, he or she should be able to feel an obvious rock hard abnormal prostate.
Yeah.
Now, obviously, a urologist like you who does literally millions of the exams, you're obviously going to be able to feel something a lot smaller or more subtle.
You are, but I mean, it's really not feasible to send every human urologist just to get a check.
Right, exactly.
So, it's something that I think should be in the realm of family practice. I think it's important to do the screening. Really aggressive, high-risk prostate cancers, just because you think of cancer, you think the more they are like a stem cell, the more aggressive they are. So they actually stop making PSA because they've changed so much.
Anaplastic. They've lost their characteristics.
So you may feel a hard rock, and their PSA is 2, and they have
which is low.
Gleason 9 or 10, a very, very aggressive prostate cancer.
Gleason is a scale you use to judge.
So they have a bad cancer, basically.
Stage.
Yeah. So you should do both.
So PSA could be false negative in that situation.
Yeah,
false negative.
Situation.
Yeah. Interesting. So any thoughts of why does the prostate gland generally grow in most men over time?
It's just
People talk about testosterone and estrogen and cortisol. I see all these different theories out there depending on what bottle of pills somebody is hawking or trying to sell. What's your understanding?
Yeah, well, it's clearly testosterone. I mean, testosterone and androgens are what stimulate the prostate to grow.
Now, would that be the super strong testosterone derivative dihydrotestosterone? Is that part of it?
DHT,
do you think, too?
Yep. That's what, when you're developing as a fetus, that's what stimulates the sex characteristics. The phenotypical male is that DHT. So That's a downstream metabolite of your testosterone.
Okay.
So, and we can talk, I mean, that's where some certain drugs work.
Yeah.
Like finasteride, one of the common drugs we use to treat an enlarged prostate. It blocks the DHT.
Now, are there side effects with the finasteride? Or does it make you weaker? Do you lose muscle mass?
You don't lose muscle. Actually, your
sex drive?
testosterone level may go up on the drug. Just
Interesting.
because you're blocking
Paradoxical.
it. Yeah. But about 5% of people will have a significant decrease in sex drive or libido, and some people that's pretty severe. I mean, could have some other sexual side effects, erectile dysfunction as well.
Is it bad on the liver? Maybe.
The finasteride?
Yeah.
I mean, if you have a normal liver function. Now, testosterone is hard on the liver.
Ah, okay.
That's why we don't take, for the most part, we don't take testosterone pills. We do shots, injections.
So it doesn't go through the liver as a pill.
Right. You miss that first pass through the liver.
Gotcha.
For the metabolism.
So the growth of the prostate, in your understanding, is testosterone and dihydrotestosterone, not necessarily cortisol or estrogen. I've heard all kinds of theories from a lot of different places.
Yeah.
And I just didn't know who to believe. Or I also hear this just an inevitable part of aging. It's going to grow no matter what.
Well, the stimulus is testosterone because that's what we do when we treat prostate cancer. We block your testosterone to stop the cancer from growing. And
that makes a lot of sense.
And that, there's no debate there. I mean, this is
you cut off testosterone, that tends to
studied
shrink
for decades,
and it slows down.
Yeah.
Interesting. So, let's say a guy has this, and the common term for the common prostate growth is called benign prostatic hypertrophy, or BPH, right?
Right.
So it's not a cancer; it's a common problem. And I understand you have lots of different treatments or things you can do for men with an enlarged prostate.
Yeah.
So maybe you can take me through this. You've got, I see on TV, they've got these things for a Urolift. They've got something called a TUNA, a transurethral nerve something ablation, needle ablation. That's TUNA. Needle ablation. Can we talk about those?
Yeah.
And the steam treatment. Can we talk about those first before we go on to TURPs?
So when we break down minimally invasive treatment options, there are things that we do to try and replace medications or do in guys that don't want to take pills with potential side effects for the rest of their life. Because that's what we're talking about with pills. It's not like an antibiotic you take for an infection for a week and it goes away. You've got to take these drugs forever, So one of the things we can do besides those drugs is a minimally invasive treatment. So first line, we have drugs or these treatments. And these treatments are going to be Urolift, Resume,
Resume, is that the steam? Is that the steam treatment?
And there's a newer one, which is basically a stent called iTend. Okay.
A stent, a tube?
Yeah. It's a temporary. We leave it in for about 5 to 7 days. So just to break those down, because it's a little confusing.
Yes, please explain.
The Urolift is basically works by, as the prostate grows, it pushes the walls together. So if you're trying to blow through a straw and I squeeze the sides of the straw together, it'd be hard to blow through.
Okay.
Well, that's what your prostate's doing. It's kind of like a trash compactor. The walls are caving in or squeezing together as it's growing. Mm-hmm. And then so that tube becomes a slit now that you're trying to pee or urinate through.
Okay.
So what Urolift does is it pushes that open. And we use small implants that will pin it open. So it's basically like pulling the curtains back, and that's going to hold it open.
Well, how long will it hold it open?
Well, maybe forever. Retreatment rates, we have a good 5-year data on these things, and it's pretty good. It's not going to be the same as a roto-rooter or a TURP.
Yeah, we're going to get to that in a second.
Which we'll talk about, which is a more aggressive surgery. But, we're talking about replacing medications. We're talking about something with no sexual side effects, which is important in young men.
Okay.
So we're talking about minimal side effects for something that maybe isn't quite as aggressive as a bigger surgery, but may work very well for many years.
So you have a growing experience with Urolift.
Yeah.
And it's basically favorable?
I think it's very good in the right patients. The problem is it's not it's not one size fits all.
Okay.
Prostates come in all shapes and sizes, so you have to take that into consideration. It works better for certain prostates than others.
Okay.
So there's an evaluation I do in the office where I look in there with a little telescope and an ultrasound and measure the size of the prostate, and we say, what makes sense for you? This might make sense, but maybe it doesn't. So you have your prostate's not shaped that way. Well, then there's another treatment called Resume.
What is that?
So that's the steam treatment. So basically, it's kind of like a newer tuna, where I go through a telescope where I can look in, just like how we used to, how we treat the stones. We go in with the telescope, and through that telescope, a little needle goes into the tissue, and water vapor comes out. Steam. So it's a thermal therapy.
It's hot.
Yeah.
Okay.
And that treats a 1 centimeter ball, okay, or spherical area, and then over time that will shrink down. And we treat a couple different places around the urethra. So then as that shrinks down over time, it's going to open up that channel, take pressure off that tube.
Now the prostate comes in various lobes, right? So would that be for more of the middle lobe that's around the urethra?
It's for the middle part of the prostate called the transition zone. That's where we tend to see the benign enlargement. There are lateral lobes. That's where the walls are coming together. And then there's also going to be a middle lobe, which is like a cork in a bottle. It's growing right into that. That's one of the worst situations.
Boy, it sounds complicated to evaluate.
Yeah. So you want to have you want to do an evaluation and see what's going to work.
So has this ablation, the steam treatment, has that superseded the tuna? Is that like better? The Resume, is that better than the?
I mean, I don't know if it's better. I think most people just do it now because one, it's direct vision. I can see exactly where that needle goes. It's more readily available.
Are you talking about the Resume?
Yeah.
The steam?
Yeah, versus the tuna. Yeah.
Okay.
And then next is something it's newer called I-10. So I-10 works by we go in with a scope and we deploy a stent, which is basically has 3 wires. Think of like a Mercedes symbol.
Okay.
So there are 3 wires. One goes up and then one to each side. And those expand when we deploy it in the prostate. And as they expand over the course of 5 to 7 days, that wire will go through and make a groove. So we're making 3 grooves in that prostate to help the flow. And because it's pressure, you have less bleeding. It's almost, a bloodless. You're not incising or
and then
cutting
does that
out.
come out?
And then you take it out 5 days later. Yeah. Yeah. So, and, the 5-year data is looks pretty good on that when you compare it to taking medications, and minimal sexual side effects. So, yeah, I think it's important to remember these are a bridge or something to replace medication. They're not better than a TURP. They're not something to replace a TURP or a laser surgery on the prostate.
Well, that's the perfect segue to the TURP. The TURP is I guess the go-to or the workhorse treatment for an enlarged prostate, where you put a telescope under anesthesia, put a telescope up there, and actually use a cutting loop and actually cut out or core out the prostate with electrosurgery.
Yeah.
Is that a more permanent solution, or what are the benefits of a TURP?
Well, the benefits of that is, one, it's probably going to be better long term for people with severe symptoms, urinary retention. In other words, they went to the ER, they couldn't go to the bathroom at all. They had to have a catheter put in.
And that can back up to your kidneys too. That can have life-threatening problems.
Right.
It's not just an annoyance.
And they tried medications and they can't get the catheter out. They just can't go. So they're in this severe category. I mean, it's a bad blockage. And so we're not going to necessarily mess around with these minimally invasive things that are less likely to work in those individuals. That's where something like a TURP comes in, because we're removing that tissue immediately. When you wake up from anesthesia, the tissue is gone. So, hopefully within a day or two when you get your catheter out, you can urinate.
So recovery can be that quick with a TURP.
In terms of being able to urinate, yeah.
To urinate.
Now, there are some other things, basically burning when you urinate, some irritative symptoms or blood in the urine that take a little longer. Just like if you scrape your knee or your elbow, the lining grows back inside. It takes weeks,
Takes
for
weeks
that to happen. Yeah.
with a chance of. But what's the chance of incontinence in an experienced surgeon's hands?
It's going to be very low. We say 1% to 2%. I mean, I think that's probably even high for the way we do it now.
So the risk of, if you catch it early, you don't have any complications, you don't have a cancer, et cetera, you don't have diabetes and whatnot. The regular healthy guy should have less than a 2% risk of incontinence.
Yeah.
Now, is there a diminishment in sexual function?
There is. So there's a good chance that you will not ejaculate anymore.
I've heard that it goes backwards, called
goes
retrograde
backwards.
ejaculation.
Right.
Okay.
Right. It doesn't hurt you. If
Right,
you're not
right,
trying
right.
to make babies, it's not going to hurt you.
Gotcha.
You just urinate it out later. In terms of the nerves that go to the erections, with the technology now, it's pretty uncommon. I never tell a patient there's no possible way it could ever happen, but it would be very rare because the energy is much less now, and it's so focused on the tissue, a millimeter away. It's not going to travel all the way through to the nerves outside the prostate.
So that's the TERP is the one that the go-to surgery that most urologists have experience with.
It's definitely been around the longest, yeah, and it's something you do a lot of in training. Now, a lot of us use lasers.
So what's the difference between laser and electrosurgery? What's the difference?
Yeah, basically with a laser, we're using a laser to vaporize or ablate the tissue or to cut the tissue. And so by ablating it, we're basically shaving it down, creating that channel. And so a lot of times there's less bleeding with the laser. And so sometimes we can even do people on blood thinners that have a hard time coming off of them with laser surgery.
Interesting. And is there do you have to go to a specialist with laser, or do most urologists?
A lot of urologists now coming out training have experience with lasers.
With laser as well.
Pretty common technology.
Laser as well. Interesting. So prostate enlargement, prostate issues, probably just a part of life, and not much we can do to prevent it, but we can certainly have lots of methods to treat it.
Yeah.
In experienced hands such as you. So let's move on to male infertility.
Okay.
This is where you and I work together quite a lot. Now, there are problems with low sperm counts in men, and then there's 0 sperm counts in men. That's called azospermia.
Yeah.
And azo means none in Greek or something close to that. And there's 2 causes of azospermia. One is the tube can be blocked. So if you have a vasectomy, it's called an obstructive azospermia, and a vasectomy that's on purpose. It's a purposeful azospermia. And then there's a problem when all the plumbing is there, but the testicles themselves are not making sperm anymore, right?
Right.
And what you and I see frequently, and I think this is very important, we tell it to the public, that the most common cause, and we see it all the time, common cause of non-obstructive azospermia, meaning there's no longer any sperm in the semen, is that a man's been placed on testosterone treatment. Right. The pellets, the long-acting implants, all this kind of stuff. And frequently family doctors or even urologists, I've heard up to 16% of trained urologists think that testosterone, because it boosts your libido and your muscles and sex drive, is good for your sperm, and nothing could be farther from the truth. Could it be?
Right. No, I mean, this is like a growing epidemic. Young men are out there, and, we have a growing problem with diabetes, with obesity, just generalized decrease in your overall wellness or health. And low testosterone can be a sign of that. And there's also a misconception on what low is. I mean, there's a bell curve here. We're not all NFL linebackers that can turn over a car, with their bare hands. So not everybody's going to be the same. And as long as you're in that bell curve, you're in a healthy place for your body. And, these guys go to these clinics. They're not run by urologists sometimes. They may not even be a physician. And I see guys, it's not infrequent. I mean, they're started on testosterone with completely normal testosterone levels. And they don't realize that it could basically completely shut down the sperm factory.
Right.
I mean,
completely shuts it down.
Zero. And
Or
if they've been on it long enough, It's not a guarantee it's all going to come back.
It'll come back.
Yeah.
Now, if you have a guy who's been on testosterone or has been on anabolic steroids, bodybuilding and
Yeah.
whatnot, can you talk about the medications that you can? Obviously, you need to stop the testosterone, and these implants and pellets will take a while to dissolve. They don't just stop. They don't just go away. They have to. There's a half-life to these things. It takes a while to go away. Can you talk a little bit about the medications you might give a guy to bring his sperm count back up, and which also can increase their own natural testosterone production?
Yeah. So the way that it works is that a man's body can convert the testosterone to estrogen. So we convert some of that to estrogen. And estrogen is the potent natural feedback inhibitor. So that estrogen goes back, it gets in the blood, and it goes to the pituitary gland. And it's actually the estrogen that tells the brain, hey, we have plenty of testosterone, shut down the factory. So then no more signal from the pituitary goes down to the cells that make sperm or testosterone, called FSH and LH. So
it suppresses both of them.
Suppresses both. It's not just the LH, it's not just testosterone. The side effect is the sperm. So they're both just shut down. I mean, if a guy's been on testosterone and comes in and I check the LH, FSH, they're undetectable.
Off the scale.
So what we want to do is block that negative feedback. And so there are two drugs that can do that. One is called Clomid or clomiphene citrate.
Okay.
The other one is called anastrozole. So these are both generic medications.
They're cheap and they're safe.
Cheap, safe. They're used off-label, meaning they're FDA approved for other reasons. But we've been using them in men for decades. There are lots of clinical trials showing they're safe, effective. So one blocks the production of estrogen. Of estrogen, so it's going to decrease that. The other one blocks the estrogen receptor. That's Clomid, clomiphene citrate, so that it tricks the brain into saying, hey, I need to send a signal again. I need to rev up the factory.
And that can speed up the sperm production and also raise their own endogenous, the testosterone they're making on their own, right?
Right.
Now, when would you resort to adding injections of something called HCG?
Yeah. So HCG is basically works by taking the place of LH. And so it works directly on the testicle, directly on the cells that make the testosterone. And so in somebody that is just not responding, maybe they've been on it for testosterone for a long time, they have a lot of atrophy or shrinkage of the testicles. The fact
you can tell that. You can examine a guy and tell, right?
Burned out, and they're just not responding. Then you can add that, and that's going to be more potent. But you still got to be careful with just using that. You really, sometimes that FSH doesn't respond, so you can add those other drugs to it. But yeah, definitely we can use that HCG. It's commonly used actually with people on testosterone to help prevent the factory from shutting down.
Gotcha. So it can be a little tricky to use. Let's talk a little bit about how you help us get sperm so we can do in vitro fertilization.
Sure.
I'll let people know that when humans reproduce naturally, guys are making hundreds of millions of sperm to try to get thousands of sperm up into a woman's fallopian tubes, because that's what you need to fertilize an egg. And you need thousands of sperm banging on that poor little egg to get one in. People say it takes one. Yeah, well, it takes an army to get that one in. With modern reproductive technology and in vitro fertilization, we can inject a single sperm into each egg. So if a woman has 20 eggs, we need 20 sperm. Now, if we don't have many sperm, or they're in the semen, or they're damaged, or there's none in there, frequently there's still sperm being produced in the testicles. Isn't that right?
Right.
So we do some hormone tests. I think that will give us some idea if there's sperm in the testes, right? And what can you do, Clay, to help us get enough sperm to establish a pregnancy with in vitro fertilization?
Right. So one of the common procedures I do is I will make a little incision on the front of the sac or the scrotum.
So it's a testicular biopsy. And it's done under anesthesia usually, right?
Usually.
There's the occasional brave guy that'll do local.
Yeah.
It's nicer when you're asleep. It's nicer when you're asleep.
To have some sedation.
Okay.
Yeah. And then you also make a little incision on the front of the testicle. And we actually take the seminiferous tubules. Those are the tubules that house the sperm. We actually take some of those out. And we're getting fresh, clean, healthy sperm. They haven't been subjected to toxins that you may see
Yeah.
further down the tubes or
Down
the
the
tract,
line,
the
right.
epididymis. Yeah. And we can give those right to the, like in your lab, I can give it right to the embryologist, and he can tell me in real time, oh, good, we got lots of good healthy swimmers, or not looking so good, we need more. And so we can go and get a little more, or try a different spot. And it's all done through a very tiny incision, maybe less than half an inch. So.
And guys go home later that day, just in an hour or
Go
so, put some frozen carrots
That's
or peas on their crotch for a day or two, and they're good to go, right?
Yep. Similar
Yeah.
to like a vasectomy in terms of discomfort. Yeah.
Fantastic. So with a trained urologist, we can hook or by crook, if there's sperm in there, we can usually get to them.
Yeah.
Now, I'm not going to talk about the guys who have just a few sperm here and there in their testes. There are, specialty clinics that can find sperm when there's really not many in there. It's called micro dissection, and we won't go into that necessarily. Now, are there any aspects of urology that I've not covered? Is there anything, any procedures you do that the public should know about that I have not covered yet?
Boy, we've been.
I've tried to go through the whole system. I thought I was thorough.
From a fertility standpoint, sometimes we will. I'll go in and if the ducts are blocked, I'll do a procedure to unblock the ejaculatory ducts.
That's right. There's an obstructive azoospermia that you can repair. You can fix that as well.
With the telescope, just like the BPH procedures, we go into the telescope. I think we talked a lot about most of the... one thing I do is urethroplasty. So somebody has a stricture. So
a tight spot in the urethra.
Scar tissue in the urethra.
Is it generally a man?
Oh, yeah, but usually,
Okay.
yeah. It's pretty uncommon in female. Yeah. Usually it's a man. And so you get the scar tissue. If it's real mild, sometimes we'll try stretching or dilation, or even go in and cut with a laser or a little knife through the telescope. But if it's bad or if it's come back, we have to be more aggressive, then we'll actually cut out the scar, either sew the tube back together, or sometimes we'll put a patch on there. We use a lining on the inside of the mouth.
Yeah, that's right. That's right. Sometimes you'll see cases on the board where we'll have Dr. Mechlin and one of the ENT doctors who's harvesting
the buccal graft. From
the mouth.
Yeah.
Do we see that in little boys and stuff if you're doing urethroplasties?
Yeah.
They'll use buccal tissue. Buccal is the gum, the cheek lining.
That's right.
And it'll transplant to the urinary system.
Yeah, because you think about think of how dirty the mouth is. So you have this robust immune system in that tissue. It's used to being wet all the time. Okay?
Perfect.
If you took your skin from outside, one has hair on it. That's not good.
That's not good.
Yeah. The other thing is that it's not used to being wet. Just think about what happens when your skin's like you're in your groin or if you're incontinent.
Right.
It breaks down.
Horrible.
So you need something that's used to that environment. And that's really the perfect lining is that buccal graft.
And that heals pretty good? Mm-hmm. The donor side heals pretty good?
Yeah.
Fantastic. So, Clay, I always want my guests to tell me some stories. Can you tell me like the wildest thing that ever happened during your training or your practice that would be of just of general interest? That you've encountered in your training or your practice.
Well, we can do one from each, I guess. In training, we used to cover the maximum security prison, and so there was a prison ward, and all the prisoners would come to our ER, and so the prisoners like to get out of the prison. And one way to do that is by doing something to themselves.
Oh, that needs medical attention.
To go to the hospital.
Oh.
And that usually involves sticking things in your urethra or other openings. Oh. And so, and we would see the same offenders over. You would think like they would stick a spoon or a fork up their urethra and just stuff. Or screws, and then you'd be in the ER in the middle of the night. You're a resident. You're like, come on, trying to figure out how to, could we get this out without having to go out to the OR and take 3 hours in general anesthesia, and versus just pulling it out there. while they're chained to the bed. I mean it.
Oh my!
And then they would do it again. And like one guy had an ostomy, so a urinary diversion where you have basically a bag on for the urine drains.
Okay,
so he would
not a colonoscopy, but a ureterostomy.
What? Right.
Or
so
urethral
right. So you had a
conduit or whatever they call it. Okay.
Yeah. Urinary diversion. So the urine just comes to a bag, just like some people have colostomy for bowel reasons. Urine. Well, he would stick forks and spoons up in there, and you'd have to go in and fetch them out. So the prisoners always kept us busy with some pretty ridiculous stuff. In my practice, since I've been here, one of the craziest things I saw was this guy, young guy, I mean, maybe 30, maybe upper 20s. And he wasn't married. I think it was his girlfriend. They were kind of Eastern European. And he came to my clinic for a problem with his penis. And he had gone on the internet and read or watched a movie on how to do a penile augmentation to give you more girth.
Oh, to make it bigger.
Make it bigger around.
He wanted a bigger penis.
His partner.
Uh-oh.
I don't know how much she had to do with it. And so this involved injecting Vaseline under the skin at home. So, of course, it got infected.
Oh.
And it was coming out of this. I mean, it was. So we took him to the OR, and it was really, and this is something that's out there. I mean, there are clinics in other countries that do this, a more sterile technique, but it's still, the side effects can be
horrendous,
significant. Because your body rejects foreign bodies. It wants to get them out.
Right.
So it's going to get inflamed. It's going to do everything it can to spit this foreign body out of there. So we removed as much as we could, but
did he lose his penis eventually?
No, he didn't lose it, but a lot of it was still in there. I mean, we couldn't just remove everything.
Severely scarred.
Yeah.
Or I'm going to say he now has a Franken penis.
Yeah. I don't think she was impressed. I don't think the outcome was what he wanted. But that was a pretty interesting one.
Oh my goodness. Oh my goodness, Clay. Well, I'm glad he didn't lose his penis, but boy, he could have if it got much worse.
Well, absolutely. I mean, we see in the Peyronies,
right?
It's seen a complete curly Q.
A complete curly Q. I thought 90 degrees was bad.
No, it actually, when it was erect, it's pushing against the abdominal wall like a handle, like a suitcase. I mean, just completely
all the way like
into the skin and the abdomen. It's 180 degrees.
180 degrees.
Yeah.
Wow.
Yeah.
Wow. Well, that has totally piqued my interest and I think satisfied it as well. So I think that's what I was looking for here with all the weird things we see in the practice of medicine.
Yeah.
Fantastic. Sure. Well, Clay, I want to thank you for a very informative discussion. I learned an awful lot. I really appreciate what you've done for my fertility practice. You're a wonderful colleague. I know you help a lot of people here in the Midwest with their various urologic issues. And once again, I want to thank you for coming on the show. It's really been a pleasure.
Well, thank you. It's been my pleasure.
Thank you, Clay.